Backed by popular demand, our first speaker is Dr. Matt Wilkinson. Dr. Wilkinson is a transplant surgeon at St. Luke's Health System and moved to Kansas City in 2019. He has a passion for transplants and a deep respect for organ donors and their families. When operating on an organ donor or an organ recipient, Dr. Wilkinson makes special time with his entire staff of the operating room to show appreciation and acknowledgement of the life of the donor and the special gift that will be received by a recipient. When he isn't working, he enjoys traveling with his husband Marco, taking care of his saltwater fish tank, and playing with his cats, Tiger, Luna, Gigi, and Mochi. After Dr. Wilkinson concludes, there will be time for a few questions. Please welcome Dr. Matt Wilkinson.
All right, can you guys hear me okay? All right, good morning, nice to see you. They have to add to that, I also like riding my motorcycle. That's why I have these pants and these boots on. So you can be a surgeon and ride a motorcycle, it is okay. So it's nice to see you guys this morning. I am a transplant surgeon. All those letters behind my name, I went to school to be a medical doctor, so that's 4 years. I did a PhD, which is another 3 years, and then the last ones have to do with it is the American College of Surgeons. We can take a look at the next slide. In order to get to where I am now, I am 41. I was in school for 18 years after I graduated from high school. So I was born in Colorado and lived there for a few years. And then I went to Connecticut for a few years, and then I grew up in South Carolina. I was there and I went to undergrad there, so that was 4 years. I decided to do an MD and a PhD, which was an additional 7 years. I started in Texas, and then I finished in Mount Sinai, which is in New York City. And then I did my residency in general surgery. So when you finish medical school, you don't know what specialty you're gonna do. You might do medicine, you might do endocrinology, you might do surgery. There's lots of things you can do after you finish medical school. And so I did general surgery, which is another 5 years. And then to do transplant surgery, that's an additional 2 years. So I went to the hospital at the University of Pennsylvania for 2 years to do that. And then after that, I came here to Kansas City, and I work at St. Luke's Health System, and I'm one of the transplant surgeons there. I do liver and kidney transplants. The training for abdominal transplant is different from thoracic transplant. So if you get a heart or a lung transplant, that's by somebody who went through a different pathway, learning how to do thoracic surgery rather than abdominal surgery. Okay. Any questions about that? If you do have questions, you can raise your hand in between. I'll be happy to repeat them and answer them. There'll also be some time for some questions at the end. How many people do you think are waiting for an organ transplant? Like, why do I have a job? How many people might be waiting for an organ? A lot, yeah, that's a good number. How many do you think it is? How many? 1,000. Raise your hand for me and then tell me. Yeah.
104,000.
All right, you guys have got the one you can read. I'm going to tell the state of Missouri you guys are good to go on your yearly test. Good there. So it's 104,000. The vast majority of those people are waiting for kidney transplants. Kidney transplant is the most common transplant that we do in this country. It's probably on the order of around 20, 25,000, things like that. So kidney transplants certainly are the most common transplants we do. Liver is the second most common, followed by pancreas. You can do a kidney and a pancreas together. It's often done for people with diabetes. Most adults in this country who are transplanted for a kidney have either high blood pressure or diabetes. That is generally the cause of kidney failure. Children can also have kidney failure for a variety of reasons. Those tend to be more things like genetic reasons. Liver transplants used to be most common for hepatitis C. There is actually treatment now and a cure for hepatitis C. So most liver transplants nowadays are actually done either for alcoholic liver disease or due to fatty liver. So as you know, as you may or may not know, there's an increased rate of obesity in the country, and that causes an increased rate in liver scarring and cirrhosis. There are also heart transplants, lung transplants, intestinal transplants. Some things that are coming along, there are also people who have had face transplants. You might see that in the news. That's much less common. Some women have undergone uterine transplants. Those are quite uncommon, but those are done so that those women can bear children. That's really probably more on the horizon, but it has been done. Probably about 70 total children have been born from that. And so all in all, about 104,000 people. But that's a day-to-day change. So if someone gets transplanted today, if I go do a kidney transplant this afternoon, that person comes off the list. But then when we meet in our committee tomorrow and talk about all the people that have come through the clinic, those people are going to get added to the list. And the problem is we don't have enough organs for everybody that wants one, right? So I can't go down to Target or Walmart or wherever it is you want to go and get a kidney or get a liver. So people have to wait. Unfortunately, not everybody can wait long enough. So there are people that die while they're waiting for an organ. Their organs fail. How many people a day do you think that might be? 100? Not quite that high. So it's 17. There are 17 people in this country every day that die waiting for an organ. So either they succumb to their disease, something else happens, they get to a point that they're not able to be transplanted. And so that's why it's so important to talk about being an organ donor, because the vast majority of the places we can't, like I said, we can't go and pick up an organ. The organs come from people that choose to donate their organs. And in this country, organ donation is an opt-in system. Basically, you make a choice to be an organ donor. Usually it's done, they'll ask you at the DMV, do you want to be an organ donor? And then they put that little heart on your license, and that means you've chosen you want to be an organ donor. The systems in other countries are very different. In most European countries, it's actually generally an opt-out system. So the system is set up whereby everyone is assumed to be an organ donor unless they say that they don't want to be an organ donor. And there's a variety of reasons they may choose not to do that. So this is a picture in the operating room. I'm there on the left. The gentleman on the right is one of my surgical mentors. And you can see that when we're sewing in an organ, you can't just sort of put it in there and hope that it works. You've got to sew it into something. And interestingly, every organ is a little bit different. So when we do a kidney transplant, you may or may not know, your kidneys are up here in your back by your bottom rib. You got one on each side. Okay, so you have two kidneys. They last as long as they last. We don't put the new kidney in the same place. You guys know where we put the kidney? Down here. The new kidney actually goes down here at the bottom of the abdomen. So we actually sew the new kidney into the blood vessels that go into the leg. It's much closer to the bladder, and the kidney works just fine. You can put the kidney in upside down. It'll still do its job. It doesn't have any problem with that. So that's called a heterotopic transplant because we put it in a different location. Other organs, like the liver or the heart, have to be put in the same place. So if I'm doing a liver transplant, your liver is your biggest internal organ. It's a big triangle is what I tell my patients. It kind of goes from here, all the way up and across, back to here. It's the biggest internal organ you have. You know what your biggest organ is? Your skin, exactly. All right. So your liver is your biggest internal organ. The old liver has to be taken out first in order to put the new liver in. Similar for heart, similar for lungs. Those are called orthotopic transplants because they're put in the same location. So on the right is a diagram, and on the left is a picture of an actual kidney. That kidney does not yet have blood in it, and I know that because it looks like a piece of chicken breast. Normally kidneys, when they have blood in your body, they will look pinkish to purple. That's normal because they're perfused with blood. And your kidneys weigh about 1 pound. You have 2 of them, so if you think of your total body weight, 2 pounds of your body weight is your kidneys. They get 20 to 25% of the blood supply from the heart every minute. That's how much filtration they're doing. Your brain is another 3 pounds, it gets another 20 to 25%. So you've got 5 pounds of organs, your brain and 2 kidneys, that are basically getting 50% of what your heart puts out every minute. When you put the kidney in, you can see up there on the top right, the kidneys you're born with, again, are up here in the back. We do the transplant in your lower abdomen. It can be done on the right, it can be done on the left. It doesn't make a bit of difference. And we sew it into the side of the blood vessels going into the leg. What I tell the patients, it's kind of like adding an exit to the interstate. The blood can still go down into the leg, but now some of that blood gets into the kidney. We plug the ureter into the bladder. The ureter is the tube that carries urine from the kidney to the bladder. You guys are probably too young to remember this, but back in the 90s, when you had to plug things into your VCR, there were these red, white, and yellow cables you had to do to plug things into an old school TV. You guys are probably way too young for this. Everything's wireless now. Kidneys are kind of like that. They come with the 3 tubes. You plug them in and they work. Okay? It's the same idea. The kidneys come with the artery, vein, and the ureter that need to be reconnected in order to put them into place. Now, a liver is a little different. So if you look at the picture on the left there, like I said, your liver is your biggest internal organ. And your liver has two big functions in your body if you think about it. It's like a big factory. It has synthetic functions. It makes lots of proteins. It makes all your clotting factors. It's a huge production place. It's also a clearance place. Most things that your body takes in get cleared through the liver. So if you take a medication, most of the time that's cleared through the liver. And so that's why it's so important and why things like alcohol and viral diseases can destroy it. Now to put a new liver in, you have to take the old one out. There's different ways to do that, but the location where you put it is the same, and that's what the diagram on the right is showing you. There's a lot of different ways to do it, but you do have to put it in the same location. That's what a liver looks like. That's about the size of a human liver, so it's bigger on the right side than on the left side, and all of the vessels around on the back. So that would be what it looked like if you made an incision on someone's abdomen. That's what the liver would look like from the front. A couple new things I want to tell you about before I give you guys a chance to ask any questions is, so what do we do if we don't have enough organs, right? There's not enough organs for everybody that wants one. So you may have seen on the news some things that are coming up is the ability to engineer organs, right? So to actually grow them in the lab. Do you guys know, or does anybody know what the biggest issue with that is? With growing organs in the lab?
Stem cells?
So you said stem cells. What do you mean by that?
Getting them in a more way.
Okay, good. Yeah, so getting them in the way you need them. So scientists have figured out how to take a stem cell. A stem cell is one of the original cells in your body. It can turn into anything. It's kind of like when you're a kid, you're trying to figure out what you want to do in life. I'm still trying to figure out what I want to do in life when I'm 41. But it can turn into any kind of cell. We know how to turn a cell into a nephron, which is the functioning unit of the kidney. We know how to do that. The problem is we don't know how to make it grow the arteries and veins and the ureters we need to make it plug in. You can't just throw those cells in there. So that's part of the issue. The other thing that's being worked on is the last thing, which is xenotransplantation. So every cell in your body, other than a few, have things on their surface that say they belong to you. Okay, so that's how you fight off bad things. Your immune system says, hey, this doesn't belong here. I know that I need to fight off this bacteria. I know I need to fight off this virus. Your immune system also knows if tissue is put in your body that doesn't belong to you. So one of the biggest issues we deal with in transplant is if I were to donate a kidney to somebody, unless they're my identical twin, so their immune system is going to be the same, their immune system is going to attack that organ. It is going to attack it and say, this can't stay here, and that organ will die. That's the reason organ transplant didn't really become very feasible until about the 70s when we developed medications that can suppress the immune system. So people that have had organ transplants are actually at higher risk to get infections. They're actually immunosuppressed at baseline because we have to prevent their immune system from attacking them. Yes, your question? Okay. So the question was, do we have a way to make the immune systems weaker? We do. And so that's immunosuppression. Now, you may have also seen some things in the news where they were taking kidneys from pigs. They did one in Maryland and they did one in New York, and they put them into a human. Different animals are good, different models for looking at humans. Pig kidneys are relatively similar to human kidneys, so a lot of studies on kidneys are done in pigs. And what they did is they genetically modified these pigs so that the surfaces of their cells would not say, I'm from a pig. They're basically in camouflage. The immune system can't see them. They don't know that they're there. And so that's part of what is trying to be done, is if you could engineer organs or develop organs that did not activate the immune system, you wouldn't have to put people on immunosuppressants. Because one of the funny things about them, just a second, is that the most common medication we use for immunosuppression, which is called tacrolimus, is actually hard on the kidneys in the long term. And you'll see people get a kidney, keep it for 7 to 10 years, and they've done everything they're supposed to, but that medicine may end up hurting in the long term because it upsets the kidney, and they end up losing the kidney after be retransplanted. Yes?
So, you feel a difference after the transplant?
The question was, do you feel a difference after the transplant? Absolutely 100%. So depending on the organ that you transplant, you could be somebody, it depends on the organ you get. So if you're somebody who has kidney failure, what do we do if someone has kidney failure? Do they die? No, what do? We put them on dialysis, right? Dialysis is a machine that replaces kidney function. Patients do not like it. Most people do hemodialysis, which means in their bloodstream, they have to go to a center 3 days a week, sit there for 4 hours at a time, and sit on this machine that filters the blood. It makes them very tired, they don't feel good, it does not replace all the functions of the kidney. It keeps the blood clean, and it keeps the patient alive, but it certainly doesn't make them feel better. If you want to hear a crazy statistic, if you take everybody in this country who starts dialysis this year, how many of them do you think will be dead in 5 years? What percentage? 50%. People do not live a long time on dialysis. So, to your question though, do they feel better? Absolutely. It's funny, you make a big incision on somebody's belly. So a kidney transplant incision is like this. It's like a backwards J almost, like this, because you got to get down behind the intestines. A liver transplant incision is underneath both of your ribs, maybe up to your breastbone. To do a heart transplant, you're talking about a midline sternotomy, which is cutting through your breastbone from top to bottom. They ratchet open your chest in order to put this new heart in. These people feel better than they've felt in their whole lives. They go home on not any pain meds, things like that. We know what the organs do at baseline, but some of the other things in terms of making them feel better, it's amazing how much better they do after they're transplanted. Absolutely. Other questions? Yes? How do I approach a transplant? A partial transplant, like from a living donor? Okay, so you can do living donor transplants. So one of the important things is normally we get organs from deceased donors. That is the most common source of getting them. You can get organs from a living donor. You do have 2 kidneys. You don't need 2 kidneys to live. When we do a transplant on someone, we only give them 1 kidney, correct? And that's enough to keep them off dialysis. So if your 2 kidneys work well, and you would like to be an organ donor, you get worked up, they make sure it's good, and then we come in and we talk to them, and if someone wants to be an organ donor and they're otherwise medically healthy, they can then choose to donate a kidney, and the other kidney will do about 70% of the function in the long term. So each kidney does about 50%. When you take out one, you immediately cut kidney function in half. That other kidney figures out, hey, I'm the only one doing anything anymore, and it'll pick up to about 70%. Now what's really wild is your liver, you can also do living donor liver transplants. The liver is the only organ in the body that regenerates. So you can go in and someone who's otherwise healthy, you can take up to 70% of their liver. You can take that out, the liver in the donor will grow back to the size they need, and the liver in the recipient will grow to the size they need. So you can do living donor liver and kidney transplants, absolutely. There's another question. Yes?
How many transplants have you done in your career?
I would say for kidney transplants, probably 500 and maybe 600. Liver transplants, probably 300. When I was in fellowship, we were doing about 120 transplants a year. There weren't a lot of work hour restrictions when you're a fellow. Yeah, another question?
What do you say the success rate on a living liver transplant is?
Success for a living donor liver transplant, every program is going to be different. It's probably pretty much close to 100%. Living donor transplants tend to work better simply because they're outside of the body for less time. So like let's say that I was donating a kidney to someone, they would, like at the end of the month, Thursday I'm doing a living donor kidney transplant. So I will have that patient in the operating room. I will take out the kidney. My partner who's going to implant the kidney will be next door and already have the exposure. So the organ is out of the body for less period of time. We know the longer the organ is out of the body, the more likely it is to have problems. The other thing is to be a living donor, you've got to be pretty darn healthy. So the organs themselves are generally pretty healthy, whereas from a deceased donor, you look at the thing. So like if you're somebody who's young, you're 20 and you need a kidney, we're going to try to get you a kidney from somebody that's young. But if you're say 65, you might get a kidney from somebody that's 60 to 65, that maybe it's not a Maserati of kidneys, but it might be like a Toyota Corolla. It's going to work just fine and go for 200,000 miles, you know? So the point is we try to match that. You can't be too picky because we don't have enough organs for everybody that needs them. Any other questions? One more question. Yes? There's not a major difference in those. They basically, so classically, immunocompromise was oftentimes used, I would say, in people associated with other, either genetic defects in the immune system, people that had underlying HIV, those were common times you'd see that. people who are immunosuppressed versus immunocompromised, they're probably very similar in what you'd say. I wouldn't say that someone on transplant, unless they're on extreme immunosuppression, is that suppressed, but certainly in the first year, especially with kidney, we do give medications which destroy most of the memory white cells, the white cells of your cells that fight infection to try to minimize risk of rejection. Thank you guys for your attention. Nice to talk.